Well, it's indeed a privilege to be here speaking on these misadventures with the chickenpox vaccine. I have a copy of pretty much a narrative of my talk that is included for your review perhaps later. I'm mainly going to work from the slides, but we'll talk about what will hopefully prove to be what someone called an intraocular trauma. It'll hit you right between the eyes when you hear what I have to say. I've always enjoyed whatever work I've done. I'm a computer scientist, so I've worked in a wide range of fields, always with a lot of zeal. And so I came to apply for this research analyst job. I had a statistical background. I had taught at a university, statistics, digital logic design, and switching theory. And I had always been involved in many scientific endeavors. So I brought a kind of uniqueness to the group because I really didn't have so much of a medical background. But I don't like to brag on myself, but I wanted to quote, I got an email from one of the top epidemiologist modelers at the CDC, and he wrote to me. He goes, your work, and he's talking about me, Goldman, it's really a Ph.D. in computer science. He goes, while not mainstream epidemiology, and he put in parentheses, not a criticism, why should it be? He said that my work was rather extraordinary. I believe we can do some truly great work together and communicate it to the folks who need to learn about it. Best wishes. So really in my job, it went smoothly for 5 years. And let's try to go through these so I can keep this logical. So I was hired. There was my little card showing I was with the Varicella surveillance project. Surveillance meaning we were going to actively track every case of chickenpox in a community. What was interesting about this community, it was geographically isolated. Many people attended schools and physicians within that community. It was like ideal for sensing sensitive trends in data. We had 300 surveillance units, daycares, schools reporting to us, physicians, clinics, hospitals, every known element in this Antelope Valley, a community of 300,000, would report cases of chickenpox to us. And we would follow up by calling the parents and getting family history and background on other children. So really, we were going to produce perhaps some of the best data ever collected in history on this disease of varicella. This is just some of my background. I ended up doing peer reviews for many different journals. At one point, for a good number of years, I started a journal, Medical Veritas, Medical Truth. I sent it in to get approved by the National Library of Medicine, but it was too truthful. And so, but I kept it going. I had a peer review panel. I got introduced to I reviewed with that maybe some 200 papers from scientists, doctors around the world, including Dr. Wakefield, many known brilliant scientists. Let's see. So I served there for 8 years. I was the sole research analyst. I handled every piece of data that went through the project. And I wasn't told much about the disease. They said, here's what we're going to do, and I had to fabricate a way to store over 150 clinical and demographic variables. I learned a statistical technique called capture recapture that allows you, if you're collecting cases of chickenpox from schools and from physicians. You can find the cases that are the same that are reported by both groups. And you can actually do a calculation that will tell you the percentage of missed cases that you missed. So instead of reporting incidence rates that were related to just reporting to the project, I could get a sense of what the real rate in the community was through application of what's called capture-recapture. Where did I learn that? At a CDC seminar. They had us attend for multiple days, and we were instructed how this technique could really enhance surveillance. Let's see, I do hold a patent. It's expired now, but for a power wheel, I developed the first computer-aided drafting system prior to AutoCAD, a well-known system today. But let's go now and talk about varicella zoster virus. Chickenpox comes from this virus, VZV we call it. The same virus produces shingles. So after you've been exposed to VZV, the varicella zoster virus, you will manifest that rash that is known commonly as chickenpox. We call it varicella. When somehow, and it's not fully understood, when your antibodies for VZV decline, your body produces an endogenous, an internal boost, and you're boosted again, and that prevents you from getting shingles. So you don't catch shingles. You catch chickenpox first. The virus goes dormant in your body, just sitting there. And usually when you're way older, you got shingles, maybe in your 50s, 60s, or 70s, due to a declining immune system. And that's how shingles was explained. We'll look at some curves. The incidence in children was very low for shingles, and as you got to adults, it increased, and older ones, it increased greatly. But it wasn't really an age-related decrease. What I found was that it wasn't this endogenous boosting that protected you so much. It was the exogenous, the outside boosting, that every person in the population received a boost, like a vaccine booster, but it was subclinical. When you're near a child with chickenpox, contagious, natural chickenpox, it provided an immune system boost to all adults, and that could protect the adult and postpone the outbreak of shingles. So that if you have that basic concept there, the exposures to chickenpox, families that live together with grandparents taking care of parents and grandchildren, in communities like that, shingles, also called herpes zoster, was very low incidence because the older ones got boosted from younger ones. Well, we'll see this a little later. I'm getting ahead of myself. So chickenpox was generally a benign disease. CDC would advertise that it produced death. And true, 50 children and 50 adults per year died from chickenpox. You actually had maybe a greater chance of dying from a strike of lightning than for that disease. Let's see. I'm going to go to shingles, on the other hand, manifests itself by a painful rash in what's called a dermatome. So you can easily, all doctors distinguish herpes zoster very easily on presentation. The rash will be limited to an area. It can be so sensitive, just air will create pain, or clothing rubbing on the rash. And it can occur in all parts of the body because herpes zoster can attack any nerve in the body. In the head, there's the trigeminal branch that goes to the eyes, to the ears, to the nose, to the mouth. So you might have heard of Bell's palsy, a partial paralyzing of the face caused by herpes zoster or shingles. Let's see. So shingles has many manifestations because it can really affect any nerve in the body. Some people mistake it even for a heart attack. They end up with bladder problems, balance problems due to shingles. The rash can be quite painful. These are typical ones. In children, it is generally a lighter rash than in adults. And so really, when you consider varicella vaccination of children, you're considering one component of VZV, the varicella herpes zoster virus. And really, 25% of medical costs are, oops, I pressed the wrong button there, are due to varicella. But the large majority, 75% of medical costs are due to shingles or herpes zoster. So let's say you eliminated chickenpox altogether. If there was an increase to shingles, you completely offset the cost-benefit analysis. And just to give you a preview, shingles in adults has increased nearly 100%. Because of that lack of the boost due to the natural contagious chickenpox no longer is providing that exogenous outside subclinical boost. So chickenpox was a great success. We went, you can see an 80% decline from 2,934 cases reported to our project in, keep hitting the wrong button there, in 1995 versus 587 cases in 1999. It seemed successful. Let's go ahead, continue universal varicella vaccination of children. Well, you have to understand, why would you vaccinate every child? Well, in Japan, they showed that children maintained their antibody titers were higher after 20 years after being vaccinated. And so it seemed to be of long duration. This one vaccine was going to give immunity forever, for lifetime. But what they didn't tell you was in Japan, only 1 out of 5 children were vaccinated. That left 4 out of 5 with natural chickenpox, providing the outside boost to effectively seem like the vaccine was very effective. So initially, one vaccine was reported as 84-point-something% effective, but the vaccine was being boosted by natural chickenpox. It was boosting the vaccinees. Okay. Shingles cases, though. What happened, I'd like to read an interesting point here. In the, well, let's see, I don't have it handy here, but in the base agreement that the FDA signed with Merck to license the vaccine, and I was unaware of this when I joined the project, it said that the vaccine may increase the incidence of shingles among those vaccinated and those unvaccinated. Now, that's a key point. If that's going to happen when you make a varicella surveillance project, why don't you also do surveillance of shingles to see what the expected effect is on those who even weren't vaccinated, but as adults were going to lose the boost and have onset of shingles? Well, so you can all reason this out. What should have been done? It should have been the varicella and herpes zoster active surveillance project. Just ask the same reporting sites to report the same disease. So from 1995 to 1999, we were only collecting varicella, chickenpox cases. So why would they choose not to track shingles? Well, they knew the answer. They knew that there was an immunologically mediated link between the diseases. If you shut down contagious chickenpox by vaccinating, you're going to increase shingles. And they did not want that effect to be discovered. So let's just report all the positive, that other slide, an 80% decrease in chickenpox. But I heard nurses, longtime nurses, reporting for the first time that their school children were coming down with shingles. And so I said, let's make a proposal on the renewal of the grant and now track shingles. And amazingly, they agreed. In their minds, it would take 15 to 20 years for there to be a trend, and the vaccine could go on, but that wasn't the case. The first year, I found, in year 2000, I found an unusually high number of cases of shingles. And I didn't have the background baseline data from 1995 to 1999 when the project started. So there's no baseline data. They say, Goldman, you haven't proved a thing. No baseline data. It's too bad we didn't start doing this in 1995. I said, okay, well, let me look at all the studies and look at the variation in shingles rates that other studies have reported. And shingles is very much the same incidence throughout the US, UK, Canada. And so I knew our rate was maybe the same rate I found in adults, and a very high rate, 3 to 6 times higher than what it should be. So I said, well, that's pretty interesting. I called a Merck researcher who was doing research in shingles, Dr. Oxman, on adults to try to find out what is he finding. And I got shut down on that. He called the office, he forgot my number, talked to the head of the CDC. They go, oh, you probably talked to Goldman. So then accidentally, I got a hold of some emails, and there's a whole rash of emails. How can we share with Dr. Oxman that Goldman hasn't scientifically proved a problem with the vaccine at this early date? And so those emails were kind of interesting to look at how the superiors were now viewing this finding. Let's keep going here. So in years 2000, 2001, just after 2 years, there was a statistically significant increase in every age group less than 70. Then from 2006 to 2007, I had resigned from the project, but they were looking at shingles again. Again, a statistically significant increase from 316 case reports in adults to 403. So all these publications came out that were positive about the vaccine. A paper went to JAMA, the Journal of American Medical Association, based on data from 1995 originally to 1999, and then it was expanded to year 2000. So you'd think the CDC had several years of a trend of data, but really, the vaccine came out in 1995. The healthcare providers didn't adopt it till 1996. So there was no real effect of the vaccine. Then 1997, there could start to be an effect, and basically they had 2 years of real data, 1998 and 1999. Now, why I say that is I ended up having close to 3 years of solid shingles data that they wouldn't publish, but here they want to go to the publication very quickly on this downward trend in chickenpox. And if you really study chickenpox, you find there is a naturally occurring downward trend. It peaks, and over 3 to 5 years, then peaks again, and it can decrease as much as 50%. So here the CDC wants to publish this data, this huge drop, but they started the project at the naturally occurring declining cycle. More publications, for the most part, positive. Then here's the malfeasance. Let's see. I did, the CDC wanted a study of how many people were still susceptible to chickenpox. And I said, let's just add a couple of questions asking if their child had ever had shingles, get their birth date, at what age. And so I could actually measure the rate of shingles in the Antelope Valley population. And so my superiors agreed to putting those questions in. Well, we got back the data. I found the traditional low rate among our Antelope Valley population of children had the traditional rate of shingles, almost exactly what has been reported in other studies, and they removed that from a paper that they decided to present dealing only with the varicella susceptibility aspect. They totally left out shingles in that study. Later, I published that study after I resigned, and that got rid of the objection that, oh, maybe Antelope Valley children had an unusually high rate of shingles for some reason. But this study went cumulative years in the past, showing that it matched what all other studies had demonstrated. So I resigned. It remains my typical statement. When research data concerning a vaccine used in human populations is being suppressed and or misrepresented, this is very disturbing and goes against all scientific norms and compromises professional ethics. So after 8 years, I left. And, you know, I have to tell you, you know, if you write a paper that appears, I vaccinated all my children. I went into this project naively thinking, oh, the CDC, I'm employed by a prestigious company doing research that will benefit not only our community, but the rest of the U.S. population based on policy. So that I naively went into that. My experience was far different. So then I started to want to give my project credit, at least, for all the data that we had collected. So I sent a note to the local Los Angeles and CDC offices saying, I plan these 3 publications that I had submitted for review that went without review for several years, and they wouldn't even broach the subject. And they told me, Goldman, we don't want you studying this aspect. And so anyway, they wrote me a letter to cease and desist publication in a medical journal. So I did what I learned today I did. I contacted an attorney. This Gail Askren, he had more experience as a judge and attorney than the most senior representative in LA County. And it was tough to get an attorney because attorneys have conflict of interest when they have other cases. And LA County is huge. And so he was located in San Diego. And he really put forthright that I had no intention to cease and desist. After all, everyone can get the data from CDC using the Freedom of Information Act. He went on to say that he would sue for millions of dollars based on the federal and state fraudulent acts and things of that nature. And so basically the county did not pursue their notice, and I was able to go ahead and publish. So I did publish. Notice that varicella susceptibility, well, I got to add my study that was censored. And incidence of herpes zoster among children and adolescents in a community under active surveillance, published in Vaccine, a major European journal. My excuse the excuse given to me why the project didn't publish that or present it was, Goldman, you can't produce two different subjects in one paper. And I said, well, I was thinking, well, the study did reveal these two items. So I knew eventually I was going to get the data out. Another incidence of herpes zoster among children and adolescents in a community with moderate varicella vaccination coverage. Actually, you'll see the sequential, I think, 18 pages. They published all three reports that CDC wanted to censor. So that kind of made me feel right ethically and morally. I got the information published. Other countries looked at that data. It did have some significance. So basically, the CDC challenged all those findings and wrote what they called a, quote, scientific commentary. Goldman was unqualified. The results are poor methodology. And what they wanted to do was just average all the shingles rates among those vaccinated and among those that had regular chickenpox. Now, those vaccinated were just exposed to chickenpox, so they had a measure of protection, and shingles in that group was very low. But among those that had natural chickenpox, they weren't getting the exogenous boosting, and they were manifesting high levels of shingles. And when you average two numbers, that's the average of a bimodal distribution, you get an in-between number that's meaningless. That's what they were promoting. And we'll see some other bogus studies and methods used to suppress and hide information. I called it malfeasance, obfuscation. To put it nicely, we titled it Misadventures. Oh, so this highlights a study where the CDC published data years later, and they came up, if you look at the blue field here, those are my figures, 2000 to 2003. These are the CDC figures, almost the same, very negligible difference, especially when you look at the confidence, 95% confidence interval. When you use capture-recapture, you start to get a look at the true rate. The site was being reported only 50% of the true cases, and we could prove that. Some people could say, oh, capture-recapture, it's statistics, you can generate any number you want. But I had the benefit of using a National Health Information Survey, and I could check my capture-recapture results with chickenpox and compare it to the statistics from the health survey. And I came to within 92% of what was expected for chickenpox rates by age. So I knew the method was quite accurate and that I was underestimating. So bottom line, this 28 per 100,000 person years was a figure that other huge samplings had gathered, and our data matched it when you corrected with capture-recapture. The incidence 446, this is the same rate you'd expect in adults. And so CDC finally did agree, and they used, interestingly or ironically, the same methods they criticized me for in that scientific commentary back in 2002. So they did stratify by status, who was vaccinated and got shingles, who was unvaccinated but had natural chickenpox and got shingles. So I did a cost-benefit analysis with one call from the CDC. The print version got postponed 1 year. I was told to contact CDC and work it out. No, nothing. I tried. My attorney intervened. And after a year, they said, we have nothing to add. Go ahead and publish if you see fit. So showing the CDC really has control over these publications. let's see. I went on to do other investigations and other studies. So I have some maybe 20 papers on this topic of varicella and shingles. Now, here's what happened. The CDC would say there has been no increase in shingles, and we can prove it. We have this Massachusetts study. Well, this shows you that there were 4,020 in 1 year of a Massachusetts study. And so the sample was insufficient. It didn't have statistical power to even measure an increase, where our surveillance project had 100,000 people, children or adolescents in the ages 1 to 19, and they were ignoring that huge data here and quoting a study with 4,020 people in it. It's stating to Australia, to people all over the world, well, we have mass vaccination and there is no increase in any of our surveillance sites. So this really summarizes. They were saying no change. They would attend meetings with researchers from the UK that were predicting increases in shingles, raising their hands, telling the whole audience, well, we haven't seen the increase this researcher just talked about, based on bogus studies. Observation time. My superior said, hey, Goldman, look at the 16-year study that Hope Simpson did. Hope Simpson is Dr. Hope Simpson. In the UK, he was the only physician in a community that had 510 children aged 0 to 9. He found 6 cases in 16 years and computed an incidence figure. You know what they'd tell me if I did that? I found 40 in 1 year with data that it would take Hope Simpson 113 years to accumulate. And they were saying, oh, look at this great study by Dr. Hope Simpson. It turns out his little data, he was just so efficient of a doctor in Cirencester, England, that he found every case. He had good ascertainment of data. He didn't lose cases. And his figures stand today as standards. But yet, so you can see the comparison of the quality of the data we were generating. In other studies I looked at, in the light blue, you see our Varicella project. Mainly only one, Guess et al., had a little more observation time than our study. But really, we had enough data to publish, and it was quite solid based on the meager little sample sizes in other shingles studies. Here's what happens, though, and here's what the CDC did. As time went on, these are cases of chickenpox by month, and if you look at by 1999 here, there's no seasonal variation, none of the peaks and valleys. It's ironed out. It's level. That's when the effect takes place. The boosting no longer occurs, and you will observe the trend of increasing shingles incidence. What does CDC do? They conduct a study in another community that basically looks like these, where chickenpox vaccine has not been widely distributed in the community. And they conclude, look at this. Shingles has not been affected by the vaccination program. But in our active surveillance site in Antelope Valley, almost the whole birth cohort was getting vaccinated. So in 5 years, about half the children in the 0 to 9 age group, which provide that subclinical boost, had the vaccine. Chickenpox had dropped by 80%. And so in any community, once it reaches this stage of no cyclical pattern, you will see the effect. So you might read contrary studies by the CDC. I'm not the one who criticized them. Other editors said, come on, CDC, look at a community that has widespread vaccination. At least do that. But now they could use that study that they did. Oh, does varicella vaccination increase the incidence of herpes zoster? Well, we don't know. We have conflicting studies. Well, that's how it goes. So, in 1965, Dr. Hope Simpson made a beautiful hypothesis that I happen to read about. He said the peculiar age distribution of zoster may in part reflect the frequency with which the different age groups encounter cases of varicella, and because of the ensuing boost to their antibody protection, have their attacks of zoster postponed. What that means is, on this curve, as young people are exposed a lot to chickenpox, they have very little shingles. Adults have children with chickenpox, but they're not exposed as much as children in school. They increase a little more in their rate of shingles. Adults that their children leave, maybe they're only having very little contact with grandchildren, they're not out in the community as you get older. It can reach really about 500 to 550 cases with normal immune systems. As you do get older, there is an age-related decline in the elderly. But they had convinced the scientific community that this whole curve was age-related decline when it had nothing to do with age-related. It was the amount of exposure to chickenpox that defined this curve. And there were studies among doctors who treated, pediatricians who treated children that came to their office with chickenpox. They had 1/4 to 1/8 the shingles incidence as adults in their same age category in the population. So you could figure out that exogenous exposures were very, very important. There's a little line here. It turns out many studies report a low rate of 74 cases per 100,000 in children. That's complicated because some children, especially 0 to 5, 50% of the group never had chickenpox. So you can't get shingles. You have to get chickenpox first. So when you adjust for the fact that low-age students, children, some have never had chickenpox, and so they can't get shingles. It turns out the rate in children is the same as in the next group, the 10 to 19 group, and so it kind of makes sense of the data. Okay, so in our Antelope Valley surveillance project, this was interesting. We looked at households and the vaccine efficacy within households. It started off at 87%. Well, let's see. Yes, in 1997, 1998, it went up to 94. Then 96%. The vaccine is very effective. Why? They're being boosted by cases of natural chickenpox. But then after 2000, again, the seasonality has been reduced. The vaccine no longer is working. Oh, I didn't want to do that. It went down to 74% effective, 59% effective. So there was this artificial boosting of the vaccine efficacy by the wild type circulating virus. I need to go back. CDC published a report. They said overall vaccine efficacy is 84%. What they did, they said, we looked at it by year, and there was not a statistical 95% variation, confidence interval variation between years. But there was a 94%. 95 is an artificial figure in statistics. And when you look at it by year, you see what's called the honeymoon effect. The early vaccinees being boosted to a peak of 96% effectiveness, and then the drop-off once you've vaccinated so many in the community. So again, that was a technique to mask the real trend, and they would have known exogenous boosting was important. Recent studies do support everything I'm talking about. Hospitalizations went skyrocketed. BRFSS study. The CDC used this Massachusetts study again over a longer number of years and said in 5 years, we found a 90% increase among adults or among 90% increase in shingles. So if you look hard, they do bury sometimes the truth. You don't hear a lot about that. But I had found something like a 56.1% increase over 3 years. The same 18% per year increase once the community no longer provided the boosting. Now, CDC will say, oh, but chickenpox has been increasing from even before the vaccine. But it was only a 2%. 3% level due to an aging population, nothing like 18% per year. But they tried to justify that. Let's see. Okay, so this is interesting. Oxman was doing research, and to prevent one case of shingles using the shingles vaccine is now $11,800 to prevent one case of shingles. To prevent one case of post-herpetic neuralgia, that's where you have ongoing pain, even though the rash has disappeared. It costs, in vaccine costs, $72,000. And again, to prevent a moderate to severe case of this post-herpetic neuralgia is $200,000. So we're paying out a lot of money to get very, very little benefit. The universal varicella vaccination program was adopted based on 3 false assumptions. One, a single dose at $35 would provide lifetime immunity. It doesn't. After the efficacy went down, now at age 4 or 5, you need a booster dose. The current cost is over $100. So you're talking about $200 in vaccine costs, then the doctor's visit. You're talking about $1 billion to give 8 million varicella vaccines to children because they need one at age 1 and age 5. So there's 8 million vaccines. That's close to $1 billion. And then you'll see all the adverse effects it's causing. See, the Oka virus is the Japanese strain. It doesn't match the US strain. So if someone vaccinated gets next to an adult with shingles and they have natural strain, now the child harbors 2 strains, the vaccine strain and the wild natural strain. Both can reactivate as shingles. By introducing Oka, the attenuated, weakened strain can undergo reversions and revert to a more virulent strain. And it could even be acyclovir or antiviral resistant. Then you have mutations developing with the combinations. So it's created a whole new world of what I call a cycle of disease and treatment. And they now put out Zostavax because adults were coming down with shingles and they recognized due to vaccine and that loss of subclinical boost, for $200, you get this Zostavax vaccine to compensate for the problem they introduced by introducing the first varicella vaccine. It's crazy. Now, I've been accused. There's OREC, Science Mom. Boy, they write terrible things about me. And, but really, the CDC themselves with these financial conflicts of interest, the data manipulation that goes on, you can call that pseudoscience, quackery. There's no more truth. I would say a good percentage of studies that you can pick out, there's a fundamental methodological flaw in there to promote vaccination. And it really takes a tremendous insight and study to get to that level to recognize it. So now we need 2 doses. They said, oh, we can vaccinate all we want. It won't affect anybody adults and increased shingles. Wrong. Hope Simpson, 1965, hypothesized it. Since then, there's a paper, how the Hope Simpson analysis explains the different rates in different countries by the exposure to children with chickenpox. Children in a household give those parents a lower rate. There are studies on that of shingles because they're exposed to children. And finally, the vaccine is safe. Well, in VAERS, there are many adverse reactions. There's been deaths reported due to varicella vaccine. So let's see. The conclusions are, prior to this universal varicella vaccination program, 95% of the adults had natural chickenpox, benign disease, and they had long-term immunity. The annual epidemics of chickenpox continued to protect them, give those subclinical boosts, and prevent or postpone shingles. But now, let's see, basically, there was close to 5 or more years where only one dose was given of the chickenpox vaccine. So many went on unprotected because the efficacy waned to lower than 60%. And so now we have all those individuals growing up with the case of contracting chickenpox. And I should explain that if you're introduced to the vaccine strain chickenpox and exposed to an adult with shingles or a child with natural chickenpox, there can be a heterologous, a genetic difference such that you can break out in chickenpox again. So that's going on. So it just created a very messy state of all sorts of new problems in diagnosing, because you might not manifest the same rash and other factors. Let's see, in adults, chickenpox carries 20 times more risk of death, 15 times more risk of hospitalization. After that Zostavax vaccine, there's now lawsuits. Adults are getting chickenpox. Well, it should prevent them from getting chickenpox, but it's not. It's a Japanese strain, 17 times more plaque-forming units are in the adult dose compared to the child. But adults have waning immune systems, and they can't always tolerate it, so they could break out in shingles even again. Let's see. So we now have these booster vaccines. These are less effective than the natural immunity that existed in communities prior to licensure of the varicella vaccine. So routine vaccination against chickenpox has provided continual cycles of treatment and disease. CDC quoted me on that in a paper. I was kind of happy they were getting a point there. Let's see. This shows what CDC tries to do. You have a vaccinated population that's reached 90% vaccinated with only 40 cases per 100,000 person years shingles incidence. But you still have some people that were unvaccinated that had natural disease. They're manifesting 340 cases per 100,000 person years. So the CDC accomplishes a mean of 70 cases. And you know what they say? We can't explain this. We've seen an increase of 69% among children 10 to 19, and we have no explanation because they're dealing with two different populations. You have to stratify the rates among those who were vaccinated and those unvaccinated, and then you reveal the trends. But they purposely don't do that. They did concede that it may be due to the frequency of exposure to chickenpox that is causing the increase. It may. Let's see. So I wrote a review You may have that in your packet on all the results we got from the Varicella Active Surveillance Project, and this Dr. Myers, who works for the CDC, and Dr. Jane Seward and others, criticized just a bunch of bogus claims. Oh, the capture-recapture provides a statistical instability in the numbers. But looking at the raw numbers, they spoke for themselves. The capture-recapture just refined what the true rate was in the community. And he tried to use maybe 10 other reasons that were all false, so that led to the editor wouldn't allow a rebuttal statement, so it got published in another journal. He claimed our reporting sites had changed. So in the rebuttal paper, we show how consistent, around 309, 317 reporting sites, how the data collected was very stable. Let's see. The result I got historically in the Antelope Valley matched other historical sites, so there wasn't anything extraordinary about shingles among children in our special community. Looking at susceptibility, we matched other studies almost identically, so our data was accurate in every way you could try to challenge it. There was always the backup. Oh, maybe doctors are diagnosing shingles more in the valley than other places, but the control was among vaccinated, the number was very low. So there were different controls that you could use to really pick out the facts and details. Let's see. Let me go to, oh, he then said there was no laboratory confirmation of the shingles cases in the Antelope Valley. Well, there are papers that shingles is diagnosed with practically 99% accuracy. The clinical symptoms, you can look at it and diagnose it properly. Canada has reported increasing incidence since adopting universal varicella vaccination. Let's see. This is interesting. I threw this in here. You know, every time a child gets vaccinated under the age of 2, there's likely damage. Now, there's been talk, oh, I don't see the damage. I can't physically see it or mentally comprehend it. But this is going to be a new source of research to do. Cytochrome P450 is a liver enzyme. 10% of the population doesn't have it. That means you cannot get rid of toxic components, the adjuvants in the vaccines. The liver just doesn't do it. And mankind is just discovering the nuances, how the immune system develops. And so this needs some further research. Under the age of 2, an individual cannot really excrete the toxic components of vaccines. Here, this is interesting. There was an 800% increase in autism spectrum disorders reported between 1990 and 2000. That was when thimerosal, the accumulative effect in all the vaccines, occurred, and yet they say they don't know why there was an increase, although by 2002, the vaccine manufacturers voluntarily removed thimerosal. Now aluminum is the big talk. But thimerosal is still in the influenza vaccine. Some people misquote and say it's been taken out of all vaccines. It's also given to pregnant women, the influenza with thimerosal. Let's see, I have a little more time. They were saying the flu shot is safe for pregnant women. Let's see. Dr. Tom Shimabukuro, though, had accumulated 170-some cases of reports. Right after the pandemic flu vaccine, women were experiencing a spontaneous abortion. And they would get a sonograph, and the doctor would say, yeah, we don't understand it. It looks like the child died right after you had our last visit. And how are we doing on time? Oh, okay. So let's see. I have to show this. So CDC published a paper that went up to the period of the spike. They were accumulating that spike data when they said the vaccine is entirely safe. Only 1.9 per million babies born to vaccinated mothers will experience a fetal death. But now, with the seasonal and pandemic vaccine being issued, the fetus was getting an overdose of mercury. And they ended up publishing another paper saying, now get this point, no unusual pattern in the data. No unusual pattern, that spike. And they said, oh, well, maybe it was due to people talking about pregnancy and vaccines. The hype on the internet was causing these spikes. They were trying to think of something. A letter sponsored by CDC and nine nonprofits went out saying that the influenza vaccine is totally safe. Yet they were getting, when I used capture, recapture, and other databases, my figures, which were underestimates, were 500 per million, not the 1.9 per million deaths, fetal deaths. So I looked at Guillain-Barré syndrome. It had the same spike. Nobody was advertising that too openly, so that served as my control, that this spike was real. This is a chart showing, based on the EPA, how much mercury a small infant can really receive. And as an embryo and developing child, they could get thousands of times the exposure. So, I could go on and on. Varicella is just one tip of the iceberg. And if you look into every one of these vaccine studies, really, my experience has been they're filled with, sure, data, but it's bogus. The way it's presented is, and the way the study methodology is fabricated is to promote vaccination. CDC distributes those vaccines, and they want those vaccines to be administered. So, I hope as a takeaway, you can take my experience. I took my job very seriously and tried to generate as much data that was real, and many others, scientific people, confirmed what I found and criticized CDC. So much of this project will have to be carried on by you in the audience, but feel free to share my experience. And I have I have 1 minute. What do you call an acid with a bad attitude? Amino acid. Anyway, I want to leave on a nice note. And after this presentation, I will be outside, standing outside, so you can just tell everyone, if they ask about me, Gary Goldman, that I'm outstanding. Okay.